Thank you. Good morning, and good morning to all the judges and delegates here. First, I'd like to thank APO AIOS for giving me this opportunity to speak to you on the tunnel and track technique of GDD implantation. No financial disclosure with respect to this presentation. The technique of tunnel and track tube placement we have been following for quite some time, and it entails making a scleral tunnel about 4 millimeter away from the limbus, so that this tube is snugly fit inside the tunnel. So you create two grooves on the sclera, use a crescent blade to make a tunnel, and the tunnel is created by the full thickness of the tunnel being created by this crescent. And after that, what you do is use a 23 gauge needle, introduce that needle into the anterior chamber or into the sulcus, as the case may be, and create the track technique. So you have a distal track and a proximal tunnel. The advantage is that the whole length of the tube is covered, almost 8 millimeters of it is covered, so very less chances of complications in terms of tube exposure or tube retraction or tube misplacement. So this is a video which just shows you how to create the tunnel and track technique. So this, you would notice this is a limbus-based congenital flap, so it's easy to access the site where you're going to implant the plate of the GDD. And once you've done that, you don't want the tube to be interfering with your tunnel creation. So you put it between the sclera and the plate. So it goes and hides there till you create the tunnel. And this is the first groove being made proximally, and the second one made distally from you. And once you made the groove, it's partial thickness. The 15 number blade helps you to do that because the bevel of the 15 number blade is 1 millimeter. If you enter half of it, if you enter half of it, then so this is the so you can see the tube is not coming in the way of creating the tunnel. And you use the 15 number blade again on the opposite side, as you are, because you don't want to enter into the track area. So as you approach the tunnel, you use the 15 number blade to lift up the crescent, which is shown here in this video. You get back the 15 number blade in your left hand, and then once it touches, you lift up the tunnel, the crescent, and you create a tunnel through which the tube can be placed. And you can do that inferiorly also, infranasally if you're wanting to place, or infratemporally you want to place the GDD. Again, the principles are the same. You make two grooves, and here in the inferior it's more easily done because you are going from the proximal to the distal again, so you can do it very easily and introduce the tube through that site, so you have a tunnel. You don't have to use a patch graft for this because it's already intrascleral, and the tube is a non-collapsible lumen, so unless it gets really tightened by a suture, it won't really collapse. The lumen remains, it may distort, but the lumen doesn't collapse. So that's the beauty of using such silicon-based tube devices. They don't collapse of their own unless the external compression is applied to that. So the sclera can accommodate the tube and the flow can occur. So this is a patient who had a trap done, and we use the same technique. You can see there is no, it's all under the sclera. You don't see any increase in profile of the tube to cause complications. And gonioscopically, you can identify the tube being in the very close to the PI area of the previous trap, and it's very close to the ciliary processes. And this again a patient with ICE syndrome who has got a well-dilated pupil, and you can see that tube is having very low profile, and it's behind the iris. It's coming into the sulcus, into the anterior chamber, which makes it easily visible. And the blue suture which you see is a ripcord suture, which is placed in the lumen to reduce the chance of hypotony. So we did a small study also. Is it time's up? And you can see that between the patch graft and the tunnel and track technique, there is very less difference in the intraocular pressure control as well as the medications. Thank you very much for patient listening.
Thank you, Dr. Ganesh. It was a very good idea to take help of the BP knife to come out on the other side of the crescent knife. But the only problem is when you're making such a long tunnel, by the edge of this crescent knife may cut your scleral tunnel in the sides.
True, yeah, that is true. So we, scleral tunnel, everybody is familiar with. We use it for SICS. And avoiding patch graft, another important thing is we can avoid transmitting prion diseases, because prion diseases are something which really serious, but it's not very commonly reported. But that's a theoretical risk of transmission when you use a patch graft.
Great
The
show.
tube of the GDD enters the anterior chamber at the distal end of the tunnel, is it?
Yes, madam. So we make a track after that. We use a 23 gauge needle and make a track to enter into the antechamber. So that allows you to either be in the antechamber or into the sulcus.
So these cases which require GDDs are advanced glaucomas.
Correct, madam.
And would you believe that the sclera remains in this structure and this configuration to get a tunnel made, and the, there's thinned
Absolutely,
out
because
sclera
we
and
have
staphylomas are there most of the time, and scleras are already
very
compromised.
yeah, by the time the staphylomas form,
Yeah.
they are actually end-stage disease. We
So,
don't do these procedures for them.
yeah.
We do it for eyes which have good vision. So those scleras are always 1 millimeter thick. Sclera
So-
cannot change anatomically. It's always 1 millimeter. So that's the advantage of using this technique. If you have that, if you happen to have a site of sclera, then you have to avoid it. Then you use a patch graft over that. But we have not experienced, and we don't operate such cases anyway. By the time they have staphylomas, they're already blind. So we do some other procedure for them, like a cryotherapy or a cyclodiode or something like that.
Okay, but we do believe that in advanced glaucomas you have changes over the sclera to get
Definitely,
this kind of tunnel and this kind
yeah,
of
and the
structures.
areas where they become weak are near the muscles. So you are operating between the muscles, so that gives you a leeway of putting it. We have cases like that, but we have taken it through the between the staphylomas.